Happy Wellness Wednesday. I am here in the afternoon instead of our evening time slot because I am with Kate Stoker, who is in Scotland, and we didn't want her to have to talk to us in the middle of the night. So we're coming to you this afternoon. I'm Laurel Brennan, and this is Brain Wellness and Dementia Prevention. And welcome, Kate Stoker.
Hello, Mrs. B. How are you doing?
Everybody who was waiting to hear your accent is very excited right now because you have such a beautiful accent. We'll try to concentrate on the words that actually come out of your mouth because those are quite important, more so than the accent. I'm going to give a quick background on how I know you. And I'm quite lucky to have been your protege, your mentee. And I got the wonderful experience to work as an occupational therapist in Scotland. And well, we'll talk about some of the differences between the US and UK. But let me give a little background. This is Kate Stoker, and I'm reading from her retirement letter that was posted October 14th in 2021. So it's goodbye from Kate Stoker, AHP, what does that stand for? AHP.
Allied Health Professional.
Allied Health Profession Coordinator, yes, for older adult mental health services, who recently retired after 34 years with the NHS or National Health Service in Forth Valley, Scotland. Kate began working as an occupational therapist in the former Falkirk and District Royal Infirmary, and then moved to Belsdyke Hospital. 6 years later, she transferred to Falkirk Community Hospital as a team leader. Kate developed strong links with the Dementia Services Development Center, going on to do her master's in dementia studies. She also joined colleagues to write and present the Practice Educators course for Glasgow Caledonian University, which she undertook for several years. In addition, her wide experience enabled her to work closely with former colleague Lynn Waddell. Did I say that right? Waddell?
Yes, you did.
Helping with the design of the Bowness Community Hospital and teaching about sensory impairment and function. Welcome again, Kate Stoker.
Hello.
So this is Occupational Therapy Month in the United States. And so I would love to hear a little bit about why you became an occupational therapist. What was your journey?
Well, actually, I had no intention of being an occupational therapist. I actually had a place to study biochemistry at the University of Edinburgh. And so I was very much a lab coat wearing person who would wander about with test tubes and going, whoa, we're going to create the next Frankenstein's monster and numerous other things, as only a 16 and 17-year-old can actually do. And what they actually did at my school was say, no, we can't just let you loose on this world and do these types of things. You have to go and do some work experience in something well outside your comfort zone. So it was literally like pull your name out the hat and you were sent off. So I ended up in a hospice working with an occupational therapist. I didn't know what occupational therapy was. I had never been in a hospice before, and to be honest, it was quite a frightening thought to go into that area. And I went and worked with this occupational therapist, and I absolutely fell in love with it. I absolutely, totally changed my career path at that point. I still embrace a lot of the science because at that time we did an incredible amount of science and we had to do a lot of anatomy and physiology and all these types of things within the training. But it totally turned everything on its head. And I applied for occupational therapy at Queen Margaret's University, and that was me. And that was about 4 decades ago. So it was really quite a thing. And it was funny. It was I actually ran into that occupational therapist. Must have been about 4 or 5 years after I graduated, and we were at a meeting, and I ran into her, and she went, She says, you came to see me. And I said, you changed my life. And that's how I ended up doing occupational therapy. And it was just something that I had never heard of. It was something that I did not even think about for a second that I would do. And yeah, best place I ever went to.
Yeah,
Occupational therapy and palliative care changed my life.
That is an incredible story. I love to hear that. I've heard many stories similar to that, in that people didn't know what occupational therapy was, and then they got exposed, and it became their calling. Like they were drawn to it. They couldn't not do it. And that's sort of a path similar to what I took. I thought I was going to be a psychologist. And then I went and met interns, and they said, no, don't do that. I have a load of debt and there's no jobs. Then all the jobs are going to social workers. Then I did an internship with social work, and they said, no. It's just like putting a Band-Aid on a problem. I'm not solving anything. If I could go back, I'd be an occupational therapist. I said, what's that? And that's how I went down that path. And once I really learned, it was a calling for me as well. I love that story. So back in 2003, my husband was working on a PhD at Stirling University, and I was told by all of my occupational therapy advisors in the US, you were going to love doing occupational therapy in the UK. It's very much what we are taught in our OT training, what is like authentic occupational therapy. So it's less governed by, here we're kind of governed by insurance and productivity requirements. And so it was quite different. Actually, it was my first occupational therapy experience working in the UK. So if you can share a little bit. So I guess you left palliative care and moved into dementia service. When did that happen?
I did the palliative care. This was actually while I was at school. I got this experience of it, and this was before I went to university. So I went to university, and we basically got a chance to do everything from have a cadaver on a table and cut up the cadaver. My friend was a physiotherapist, so unfortunately she had the body the week before us. So I was talking to my friend and I said, so what did you do? She went, oh, she says, we actually removed the skin and fat and whatever like this. And I was like, oh, okay then. So she did that 1 week, and then we got the cadaver the following, and then someone else took it and cut it into bits. So the dentist got a piece from the ribs upwards, and so-and-so got this bit and so-and-so got that bit. So we did anatomy. It was as revolting as you would imagine, because at that point health and safety was not great. So part of the exams were that you actually had to move this body into different positions and then describe the muscles that you moved and the nerves and the fulcrum movements and things. So we went from that to areas where we would be blindfolded, or we would wear earplugs, and we had to actually cook a meal. So we had to actually experience and then describe how difficult it would be to function. And then we went from there, where we would then go and do drama and movement and look at balance and look at all of these types of things. So it was one of these incredibly diverse courses. And in between times, we would go out on placement. So we would go out and we'd work with people. So it would either be, I think I worked in spinal injuries. That was one of the first areas. Neurology, did a little bit of mental health, but I didn't like it, which is quite surprising. It just didn't fit me at that time. And I remember sitting in a lecture theatre, and we were in at the University of Edinburgh. So you can imagine we were in this amazing, and it was all this oak around you, and it was all very atmospheric and everything. And one of the questions they asked which I thought was really quite surprising at the time, was give us a show of hands who would like to work in psychiatry, the field of psychiatry, because we didn't call it mental health then, it was a field of psychiatry. And there was a few brave souls put their hands up. And then they said, keep your hand up if you're going to work with older people and older people with mental health issues such as dementia. And honestly, it was like tumbleweed. There was nothing. No one moved, no one put their hands up or anything like that. And then we began the discussion of like, where do you want to go? Where do you want to go as an occupational therapist? Where do you want to practice? And people chose, and sorry about this, but they chose the sexy things, neurology or spinal injuries, or we want to do these types, or paediatrics was a massive area. And nobody wanted to work in old age psychiatry. So when I graduated, I followed everyone else out. I'd worked general medicine, then I worked in neurology. And it happened that I had the experience of actually working with the most amazing psychiatrist who was in her 60s. She had a sports car. She wore these flamboyant scarves. She was always whizzing about the place. She had a bag that had everything in it you could possibly want. And she was just a real character. And I was working with her with a particular patient who was very, very complex, lots and lots of needs. And she said, do you fancy working in the field of mental health? And I was like, I don't know. I was quite young at the time and thought, okay, if you give me a bit of training and you help me, I'll see how it goes. And that's when I moved into mental health. And it was a fantastic decision. I actually got an opportunity to, even though I was in my early 20s at that point, I got a chance to actually run wards. So I ran staff, I ran wards. I also went home every night and looked at my husband and went, oh, I don't know what I'm doing. I'll grab a book. And I think at that point it made me curious. And it made me so curious about what can I do? What can I do? And I discovered someone called Tom Kitwood, who was a psychologist. And he actually challenged the whole concept of working with dementia, people with dementia. And at that time, people who had dementia weren't people who had dementia. They were called dementia sufferers. So everything you picked up was sufferers, people who suffer from this. Everyone suffered. Whereas Tom Kitwood, what he did was he actually spoke about the person. He would say, this is a person who has this. This is a person who needs more. They need you to consider them as a person first. And this was something I'd never heard about before then. He spoke about the person, the quality of life of that person. And he also spoke about things like measuring the person's quality of life. And how important is it to know the date? Is it not more important to know which coat to wear so you're comfortable when you go outside? Does it really matter what time of the day it is? Is it not more important to actually eat when you feel hungry and eat with company? So reading his work was just such an eye-opener. It was amazing, actually. So round about 1999, 1998, 1999, I actually started working with a charge nurse who, again, like, he had read the books as well. And that's how we bonded. We were like, have you read this? This is amazing stuff here. And so we read it, and we actually decided at that point that we would do some multisensory research. We were lucky we had a learning disability unit attached to our NHS area. And so we began speaking to our learning disabilities colleagues, and we began saying, so how do you actually make sense of an environment for people who have really quite a lot of cognitive impairments? What do you do? Because we don't want things the way they are just now. We want to be able to do a bit more. We want to be able to work with the person and do as much as the person's able. So we got to experience some Snoezelen or multisensory sessions, and we began looking into it, and we actually ended up doing some research in one of the wards to actually look and see whether we could have a much more enhanced environment for people who had dementia. So instead of talking about people who wander or people who suffer from dementia. What we began talking about is people who have dementia. And if someone isn't wondering, what they're doing is they're maybe looking for something. So what could they be looking for? What can we do? So we actually developed a multi-sensory room. We did training with staff, and we actually got the nursing staff to change before they went into it, so that it became a cultural change, a physical and a cultural change. So we did some research, and it was really, really effective. We began talking about what we could do. These lights that we put on in the morning when we go in to wake people up and get them washed and dressed, shouldn't we actually be taking a little bit of time and actually considering the rhythm of the person? Do they want to get up at that time? How do we actually approach this person so that we are truly caring for that person and giving them care, and also allowing them to do as much as they can for themselves and giving us care back? And it was such a lovely way of doing it, because we were able to speak to relatives, and we were able to speak to professional staff, and we also began speaking more to the patients themselves, because it's really, really hard to know what to say to people at times. And an example of this was I was actually working with a couple of guys who had been construction workers. And you'll know this, Laurel, it's really difficult to actually engage older men in activities at times, and meaningful activities, because they're used to being out and about, and they're used to like running the finance of a home, and they have very, very traditional feelings and views on things. So anyway, I was working with a couple of guys. And my house was being done at the same time. I had no roof. So I had all these plans. So I photocopied all these plans and set up folders, and had it in. Everyone knew what my house looked like, or what my new house was going to look like. And there was pens and pencils and protractors and everything I possibly could in it. So I had this under my arm, and I was going to give it to these gentlemen, because I'd gave it to one of them, and one of them loved it. So this was a much more enhanced pack, so that they would have something to talk about and we could talk about it. And it was really successful. So as I walked past one of the rooms, there was a student nurse, and they were struggling because they were with a gentleman who'd just been admitted to the assessment unit. And he had been admitted, and he had the dreaded label of sexually disinhibited attached to him. And that is always one where everybody goes, and you're never sure what it means, how far it goes. So the student was struggling, and you could see that things were not going well. There was a certain ailment to it. So I popped in just to check everyone was okay. And so the patient themselves, pulled the paper off me and began drawing. And they took a ruler and they began drawing and drawing and drawing. And I was like, right. So I looked at the student, and we were like, and everything. And what it was the person actually drew a belt. And it was like, you want a belt? And it wasn't until then that I realised how limited this gentleman's vocabulary and language skills, they'd been so badly affected. And one of the reasons for him being deemed sexually inappropriate or sexually disinhibited was that he was undoing his trousers, and he had his hands in his pockets and all these types of things. He was really quite preoccupied. But he drew a belt, and he shoved a bit of paper at me, and I went, and the student and I looked at each other, and she went, a belt, this man needs a belt. Got him a belt, the student went off, she was fantastic, put the belt on this gentleman, and that was it. This behaviour that had dogged this man and had meant that he had moved from a general ward into a much more specialist unit was solved. And I know that sounds crazy, and it does sound crazy, but just something like that, to actually look at how we interacted with this gentleman, what we could give him so that he could tell us what he needed, was really, really important. So equally, doing all this multisensory work with people was really, really important, because the first thing that happens when people are admitted to wards or assisted care facilities and things like that is that quite often we take people's possessions away from them, because we don't want people to lose things, and we don't want them to lose their wedding ring, and we don't want them to lose their handbag or any of these types of things. But quite often we're taking away the very thing that helps that person to function. And we do it ourselves. How many times have you seen someone go into a restaurant on their own, and what they'll do is they'll open their bag, and you know they're looking for something, but they're looking for their phone, so they've got something to do, so they don't have to make eye contact, and they don't feel embarrassed about it. And yet we disable a lot of our people who have dementia by taking this away. And certainly when I first trained, that's what happened. We took so much away. We would be so concerned about people choking that everyone was given a soft diet, whether they needed it or not. We were so busy being concerned that someone would fall that we ended up putting people in big chairs and putting lap straps across and things like that. So there's no surprise that when we were asked when we were students, do you want to work with people who have dementia? We didn't want to, because it was an area that where safety was so paramount that we didn't consider anything else. We were so busy saying, oh, we want this person to be safe, that we didn't think, do you know what, they might need something else. They might want to tell us that they need something else. And the multisensory work that I did with this charge nurse, who was wonderful, gave us a chance to actually put different things in. So we got a chance to do things like, we had a bucket of split peas. We put them in the fridge so they're nice and cold so that people could actually handle things. We had extra chocolates so that if someone wanted to taste it, they could. We had things that people could lift up and put back down again. And we had a chance to embrace the person. And it was so nice to be able to do that.
Right. And when you're talking about, you know, the focus being paramount on safety, and things are taken away from them, they're, you know, restrained, whether it's physically or kind of environmentally, they're kind of contained in a certain space. It takes away their humanity. And Absolutely. When you are called as an occupational therapist to go and help people engage in meaningful activity, and then you're put in that environment, that feels terrible. So I am so glad that that transition occurred. So you saw quite a bit of change in the dementia services from when you were a student to when you retired, right?
Yes, yeah. Lots and lots of change. When I was a student, it was very much the medical model. And things were based on finding a cure, finding treatments, and we spoke about it like that. Doing cognitive assessments, measuring where the person was at. I also saw the introduction of cognitive enhancers and the use of medication as a means of halting part of the process of the dementia process. But everything that was attached to that included like detailed cognitive assessments, detailed assessments to make the decision on whether the person fit the criteria to have these medications. In fact, I was actually involved in the assessment unit and in assessing for the criteria for a lot of these types of things, or for legal decisions over the person's ability to consent and understand and make decisions about their finances. And that, so I did part of the assessment process for it. And I had a gentleman who was really feisty. He was a feisty guy. He just made me laugh. So I was sitting at a table, and bearing in mind, by then, I already had my master's degree, thank you very much, darling. And I had like, I don't know, probably 25 years experience under my belt, at least, maybe 30, something like that. So I was going in with, yeah, I knew what I was doing. I'd stopped finishing every day by saying to my husband, oh my God, what have I done today? And is this right? Onto this very much, I'm doing well here. So I spoke to this gentleman, and I said, so we're doing the cognitive assessment, and I need your consent in order to proceed with this. Is that okay? So I explained what it was. and we were going to do it because that's the way you did things. And he just pushed it back and he went, no, won't be doing that. I was like, okay, right. So I said, right. I said, so after a bit toing and froing, he says, I won't be doing any of it. He says, and I won't be going into the kitchen to see how I manage there. And I'm not taking you to my house because, well, how can you know me in 30 minutes and no, I'm not. No, you're not coming to my house either. So I was like, okay, well, we'll just get out the diary. We'll just score all of these assessments. I've only got a week to get this done, but we'll just score all this time out. And I said, what do you want to do? What do you want to do? What will make you smile? And he said, I want to go bird watching. Okay, we'll do that then. So I know, sounds, but we went bird watching. So I read up as much as I could, so I didn't appear like totally ignorant of it. I roughly worked out what the difference between a crow and a seagull was, or a crow and a peacock. Always a good move before you go bird watching, seemingly. So before I started work each day, I would rock up a couple of sets of binoculars each, and off we went to walk around the hospital. And we ended up in a bit of a field, and anyway, so we went bird watching. So for a week, each morning, we went bird watching for 30 minutes, 45 minutes. He thought it was appalling that I didn't know the difference between a sparrow and a raven or anything else that I was seeing and whatever it is. At one point, he said, I think that's a plane, Kate. And I was like, oh, I think you could be right. Okay, this is not working for me, but are you enjoying it? And we had a really good time. It was really bizarre and it was great fun. But we went out 30 minutes, 45. I basically used the time that I would have used to do a more formal assessment. We used it every day. So a week later, he said to me, he says, right, he said, I'll do the assessment with you. And he says, come on, get your pen and paper out, we'll do that. So got out the pen and paper. So we sat there and I said, I don't really need to do it. I already know the answers. I says, but what we can do is we'll do it together. So we sat there and we did the cognitive assessment between us. Now, there's two ways to look at this. Because I did the cognitive assessment with him, you could say it was less accurate because it was less validated because we were doing it together. But the other side was that he was really relaxed. So the information he gave was as accurate as he could make it. So I suppose it comes down to the question of is, why do you do a cognitive assessment? Do you do it to get a number because it's validated and its intertesting reliability is excellent because you've done it exactly the way you've been told to? Or do you do it in a way that makes sense for the person so that the assessment belongs to them? A couple of weeks after this gentleman was actually discharged, he sent me a letter, and it was basically, thank you very much. You're not just a typical TE. You're willing to get muddy. Yeah, I was willing to also put myself on the line going, I have no idea what I'm doing. And it was a wonderful experience. It's a wonderful experience. And it's not the first time that I then used that. I used it again. I had a particularly difficult lady who was a school teacher. School teachers are awful, by the way, awful to do assessments with. They just are awful because they are just so good at things and they're so organised and they're just amazing people. They've got fantastic stories themselves and they just refuse to be put into a little shoebox. So although I'm saying they're dreadful to assess, they're actually amazing to then be able to do something different with. So I was doing an assessment of this lady's frontal lobe. Actually, we were doing the behavioural assessment of dysexecutive syndrome. So the scans had said there was definitely damage there. You could see it, but we didn't know exactly how much that was going to impact on the person's abilities. So the assessment I was doing was to look at the actual abilities, and she refused to do the assessment. And I thought, it's happened before. Not just once or twice. I can deal with this. So what do you need? So we ended up doing poetry. So I had one a Burns poetry prize when I was 11. So I dragged that out of the memory and I went, I know a little bit of Rabbie Burns. So we ended up doing that and then we did the assessment. So sometimes something that you learn can change your practice. And this gentleman challenged me, and it took a wee while to work out how we could get around this, but then that became part of my tools to then work with other people. So he taught me, and that was really nice that he could teach me. And we did speak about it a little bit, like I'm a bit long in the tooth. It's quite nice to learn something new and something different. And I think that that's the thing about working with people with dementia, is that you don't know what you don't know until you start working with someone. So a life storybook is an amazing thing to do. A life storybook where you actually ask the person about their story, or you ask the family about their story. And sometimes carers, in my experience, are so busy doing the care part of it, and the medication has to be at a certain time, and my mum has to have her hair done on a certain day and all this type of thing, that sometimes you actually say, did they tell you this? Do you know this about your mum? And I've got an example. I got myself in a wee bit of trouble over this, so you might want to edit this one out a little bit. But I was working with a lady who was a midwife, and she had amazing stories. And she had the most wonderful Scottish sayings. And one of her sayings was, she would go, "Oh, when I was wee, my mum would say I was up with the larks, and I would never sit back down again. She said that I had a glass arse." And I went, "What?" And she says, "Yep, my mother says my bottom was made out of glass, or she thought it was, and so I would never sit down at risk of breaking it." And I went, okay, I've never heard that one before, but let's go with that. So there was that one. So that was one of our favourite sayings, which was fantastic. And I was like, I really like that one. And her other one was, she told me, she went, she says, "I was pregnant before I got married." And I went, "Oh, okay, that would have been unusual within your age group." "Oh, yeah. And other people joined a group. I was doing a group, and she actually she said to somebody else, she went, "I was pregnant before I got married." And the other lady went, "Were you? So was I." We had to hide it. Oh, never had. So I had this big discussion on how they actually had to hide this so they'd be acceptable people. And I said, "So what did you do? What did you do? Like, how do you deal with this?" And she went, "Well, I went to my mother, and my mother was very strict. So I went to my mother and said, 'Oh, I'm pregnant. I'm going to have to get married.' And do you know what my mother said to me? I still remember it. She went, 'Oh, hen, don't you worry about it. You've got to make sure the furniture fits the room. The furniture fits the room.'" And I looked at her and I went, and she went, "Exactly. And I made sure that furniture fit that room before I married him." And I went, "Okay then." And I was like, "Okay then." So I was talking to the family after that, and I was like, "Oh, your mother's some character." And they went, "Oh, she is. She's got the most amazing sayings." And I was like, "Yeah, she really has. Have you thought about doing a life storybook? Because not just for you or for your mum, but the stories that she has are like amazing. Like, they would really help everyone to understand more about her, but they really open up topics of conversation, and your mum will openly talk about things that maybe other people might think twice about, but like, she can really engage people, and she's an amazing woman." And they went, "Oh, so what stories stuck with you?" And I said, "Well," I said, "I knew about, like, I'd never heard the saying about the glass bottom." And then they went, "Oh yeah, that's one of our favourite ones, that we love that one." And they said, "What's the other one?" I went, "Oh, she told me about the furniture having to fit the room." And they went, so I said to them, so your mum was explaining that she was pregnant before she got married and blah, blah, blah. And there was silence. And one of the daughters went, give us a minute. She was pregnant with me when she got married. And I went, did
Oops,
you not know?
Sorry.
No. And I said, oh, she quite openly spoke about it. I didn't think this was a family secret. She told everyone in our group. And we all had this big discussion on premarital sex and relationships. And they went, and what were you meant to be doing? I went, well, I said, actually, I said, we were meant to be doing a reminiscence group. So I'd actually got things that were reminiscence on, I think it was like old sweeties and things like that. It was quite sensory based. I said, and we ended up having this massive discussion on role of women in society. And they were like, fly on the wall. I went, oh yeah, it was quite a discussion, by the way. So sometimes you never know.
Yeah.
When you open
what you're describing though is, I don't know if you had a chance to read the blog that I wrote, that I did honor you and the influence that you had on me, but it was titled the Occupational Therapy, the Art of Doing, and
yes, with
a focus on meaningful activity and just right challenge. And what you are describing encompasses all of that. You're an artist. Occupational therapists have to be an artist, and the most important part is to get to know the person in front of you.
Yes.
How can you create something that's meaningful for them if you don't know who they are? And that's what makes the job so amazing, because every single person is different. So you never get bored because you have a different person in front of you to inspire whatever it is that you're going to be doing, the art of doing. So, the stories are hilarious. Thank you for sharing those. Those are fantastic.
Oh, you're welcome. I think one of the other things that occupational therapists do is we sometimes translate things for other people. I was working with the most wonderful young psychiatrist, and amazing young man. And he had never worked with an occupational therapist before. And so to some extent, I had to nearly prove my worth, that I would have a seat at the table to make decisions and all this type of thing. So one of the things that had actually happened just before I met him, or spent some time with the consultant psychiatrist, I knew him a little bit, but not really one-on-one. I didn't really know me that well either. Was I was on the phone one day at the nurses' station, and while I was on the phone, I had my hand down, and one of the ladies in the ward actually pulled up a chair and she sat beside me, and she took my hand and she was playing with my wedding ring. And so when I finished the phone call, I put the phone down and I pulled up a chair and I sat with her. And so she's holding my hand and we were looking at the rings, and she didn't have an awful lot of language skills, but obviously it mattered. So I was looking at her ring, and we were looking at the sparkle, and we were holding them up to the light and things like that. And it was really pretty. And there was nursing staff going back and forth, and they were rushing and things like that, because that's what a ward looks like. You can't avoid that. They're busy and understaffed and things like that. And the lady I was with, one of the nursing staff, who was maybe 25 or 30, even if that, I'd walked past, and the lady I was with turned around and said, "She's my mum." And when I was describing this story to the consultant psychiatrist, I said, you could go two ways with this. I said, you could say, wow, this lady was in her 80s and she didn't understand who this person was, who this nurse was. She misidentified them and she called them her mum. I said, so that's the way you can do it. It's quite reductionist, but that's the way you could go. I said, or the second way you could regard what this lady said was, she recognised that nurse, who was one of the kindest, loving people I've ever met, absolutely wonderful, caring person who really embodied everything you would want in a really lovely motherly type of figure. She was so caring, but she was young. this lady that I was sitting with had identified those characteristics in that nurse, because she specifically chose that nurse to say, she's my mum. So sometimes as an occupational therapist, I found that actually making sense of it and saying, we've got two choices here. We either say this person's really poorly skilled and just got things completely wrong, or what we say is, what a skill this person still has, that they were able to pick up someone else's kindness and the properties that they would want in a motherly figure. And I spoke to the nurse about it as well, and the nurse was quite, oh, and I says, that's such a compliment that somebody's picked up about how caring and nurturing you actually are. And I think that was one of the other things, is that using things like the skills that I'd learned, not just as an occupational therapist, but also within the master's degree that I did, gave me more confidence to actually say, can we look at this differently? And the consultant psychiatrist and us ended up really quite close, really good friends. And I would do lots of meetings with him, with families, because he would talk about very much the medical model and the medication, and I would quite often talk about how this would impact on the person's ability to function and do things and have a life. And we would be able to do that, and we'd be able to talk about the risks and say, what's an acceptable risk? What do you think your mum would like? What would your dad like? What's acceptable? What would they want? Would they really want this? Would they want to go home? Because home is the place that we would always want someone to go back to from an assessment ward. We would always want them to go back into their community, back into their life as much as possible. So having these honest conversations with carers and with professional carers was really important, is to say, these are the risks that we are identifying. Are they right? Have we got it right? And what do you think your mum would say? What do you think is an acceptable risk? How would they respond to that? And this is where it goes back to the original part of what I saw when I first qualified, which was risk, and risk aversion was absolutely paramount now to moving towards something where you actually have these conversations and saying, can we support what is acceptable? What can we do to reduce things? And things like technology has moved forward. That's certainly helped mitigate some of the risks. Having really honest conversations with people is really, really important as well. And listening to the carers and saying to them, what do you think your mum would have wanted? Would they have wanted wrapped in cotton wool? Would they have wanted a little bit additional risk? What type of freedom would they want? How could they do that? How would they envisage their future? And it becomes a really powerful tool when you're actually saying, you know the person better than we would ever know your mum or your dad. So what do you think? Based on what you know, we can help you to some extent with the decision making. We can give you some options. We can take the decision away from you if that's what you would like, or we can help you make some of these decisions based on what you know about that person. And it does change your practice. It changes how you regard someone.
Right. You bring up some real critical areas with the safety, but also really getting to know the client, the person in front of you. And sometimes you have to go broader beyond the person in front of you to their family to really learn about who they are, who they were. And we talked about providing some practical tips for caregivers. I mean, this group is brain wellness and dementia prevention. I have moved into a prevention focus, now learning that brain changes occur 20 to 30 years before symptoms appear. It's, you know, an ounce of prevention is worth a pound of cure. Wait, do I have it backwards? But it doesn't mean that that we can neglect helping people who are already in dementia, and this is where I came from in working with people with dementia, and and their caregivers. And it seems like in Scotland and the UK, we maybe support caregivers better than we do here in the US. But if we're going to go through like a list of practical tips for caregivers, we have several categories that we talked about ahead of time. Do you mind if we go through that list together?
Not at all, not at all. I think just the one thing to say before talking about the caregivers, we actually have the Carers Recognition Act in Britain, and the Carers Recognition Act actually, by law, makes us say to carers, what do you need? They have their own right to an assessment. And that's really, really important, that within law, we actually say to people, and we direct them to Carers Centre, where they can actually talk to people and complete a carers assessment. What do you actually need? What would make the big difference? And I think that the Carers Recognition Act has been really, really paramount in actually bringing forth the fact that we know that we could never, ever, ever pay for enough care that someone needs. We just could not pay for it. It would be beyond what any budget could manage. But what we can do is say to informal carers, what do you need? What would make your life easier? Because without you doing this care and helping keep someone in the community, then this person would end up in long-term care or in a nursing home or something like that. So carers really, really matter. So working and listening to them really matters. And sometimes telling stories can actually help carers with what they're going through. And one of the things I actually talk to carers about is trying to explain what outpacing is. Outpacing is a technique. Tom Kitwood, who's amazing, he spoke about it many years ago. And outpacing is actually going at the pace where someone can't work alongside you. So the best way to describe that is if you go to the airport. When you go to an airport, what happens is that it's really noisy and there's announcements and there's lights and there's lots of things going on. But on top of that, there are people who know what they're doing, either fellow travellers or members of staff, and they are fast and they move at such a pace. And you're just trying to reach a destination so that you can get on this plane and go, oh, it's fine. Whereas they have their own agenda and they're moving at such a pace that they accidentally knock into you, or they knock your concentration, or they really put you off. And slowly you become, as a traveller, you become more exhausted. You become more thirsty. You can't find things. You've got to queue to go to a toilet. You've got to find the toilets first. You end up that you become really tetchy and you become so intolerant. And then suddenly traveling is no longer deemed this happy, wonderful thing that you would imagine it to be. It becomes this stress. You've got to be there 2 hours early. Now we've got COVID, we've got all these different rules that have come in, they keep changing, but people who are regular travellers and who know the airport know these rules. So they work at a different pace from you. So you spend a lot of time going, oh, where's, and you look for things and you're looking for things all the time. So you can imagine if you have someone who has dementia and has a cognitive impairment and who is maybe older and maybe has additional physical things like maybe say arthritis, or they may have a visual impairment or any other number of things, then each one of these things just adds weight to what's going on with that person. It's more for them to negotiate, it's more for them to understand. They just need that little bit more, and they need more time, and they need that understanding. So to understand outpacing is really, really important, is just to understand the concept of it, I think is really good. Other things to consider when working with people who have dementia is singing. Now, oh, Mrs. B, I can't sing. I really, really cannot sing. But there's a lot of research to support this as well, that live singing works the best. And the unit I was in had people who had quite a lot of behaviours that challenged, and they challenged us. They didn't particularly challenge the person themselves because they were responding to what they saw and felt and heard, but they really challenged us. And I had a couple of gentlemen who were particularly aggressive, physically aggressive. And so I was walking with a lady, and we caught a little bit of a tune. And the only thing I can really sing with an era of a modicum of reasonable success, where it's not actually making you want to open the windows and scream, is a wee bit Doris Day. So there was a bit of case and I going on, so arm in arm, we're walking along the board, and I was singing away, when I was a little girl, what would you be, and all this type of thing. And suddenly, one of the gentlemen who'd been really, 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 really quite disturbed, I took my other arm, and my first thought was, oh, okay. So we began singing. And about 45 minutes later, when my voice had completely given up, we were singing away and things like that. And I had about 7 people around me, and we were just wandering around the ward, and we went out into the garden, and we went and we stopped for a cup of tea, and then we restarted again, and we sang. And it was just dreadful, the noise, but the actual engagement was lovely, and the smiles and the swaying and the movement and everything was lovely.
Yeah, and that's fabulous.
So I can belt out a wee bit Doris Day if you really feel the need, but singing with someone, and it works really, really well.
Right.
I've used it when people are getting dressed in the morning and they're getting really distressed about it. A wee bit of a song will really, really help someone. There's some little ditties that are Scottish ones that just make people laugh and things like that, and it can diffuse a situation. And it's really nice to see. You can just see it just registering, and then that's it. You've got a common goal, you've got something really nice, and it works really, really well. I have been told to shut up, but I think that's just because someone has more insight and realises how dreadful I am. And I think it's to do with the person's insight. And I think that that's okay.
Yeah, that's funny. Good. I have to comment on that because in addition to just music bringing people together and kind of lighting up people from the inside, it also uses a different area of the brain than spoken language.
Absolutely.
And so if there's damage in the area where there's spoken language, the area where where you're understanding music might be completely fine. My dad is a retired psychologist, and he actually had a patient that he sung with in every session back and forth because she couldn't communicate in spoken language, but could communicate and understand song. So
absolutely,
it's just completely, it's amazing. When you tap into what works, then you can use that. And I want to jump back to the outpacing, the environment that you described in the airport. It goes back to in my training for occupational adaptation was the frame of reference that my advisor and professor helped to create, Dr. Sally Schultz, and she talks about the just right challenge. And it's you described it exactly. Like you have to find. The title of this talk is Finding the Right Rhythm, and it's finding that just right challenge where you create an environment where it's not too much and not too little. It's just right. You talked to. Maybe you want to talk now about the stress and distress. Does that kind of go next in the topic?
Yeah, that sits really nicely. When I first started working with people who had dementia, we spoke about sufferers, and then we spoke about challenging behaviours. That was a step. Then we spoke about behaviours that challenge. Now we talk about stress and distress. And there's lots of training on about it. You'll find it if you actually put the word stress and distress in, and people who have dementia, you'll find lots of tips and hints. Lots of it is based on considering what the person is going through, and are they stressed by it, are they distressed. So a good example of that, I suppose, is if you have someone who isn't eating as much as you would like, and who is becoming really quite malnourished. We seem to have this illusion or belief that finger foods are wrong. They should be for the later stage where someone has dementia. And I've heard people mention that, oh, they're not ready for finger foods yet. But in actual fact, it should be when the person wants to, or when they're attracted to it. So if finger foods works for someone, then that's something worth considering. Because what they may do is, you may want to consider that when they were a mum themselves, they probably did finger food things as they were putting out the plate dinner. They would have an odd chip, or they would have whatever, because quite often that's the way busy people actually did eat. And if that's the way this person's feeling, that they just want to nibble and eat and things like that because that makes them feel better and less stressed over eating, then we have to respect that. And equally, we have to look at stress and distress as in, are there other things going on? Is the reason the person isn't eating, is it because they've got a sore mouth? Has anyone checked that their dentures still fit? Has anyone actually considered they may actually have oral thrush because of antibiotics that they've been on? Has anyone considered that it could be the fact that we restrict fluids later on in the day to deal with possible incontinence, and that's actually it's drying this person's mouth out, and they're maybe having like cracks in their gum, or they've got damage to their cheek, or anything, that there could actually be another reason for this person being stressed and distressed. So do we need to actually think outside the box? So stress and distress, what it does is it gives you a framework to actually look at the whys, and it makes you curious. And that's really important. It makes you ask, but why do we think this person maybe is having these issues? Why do we think this could be happening? So instead of concentrating behaviours on the person, what we say is there anything else around that? Because we can't change the person per se, because that's just, we can't cure the illness at that stage, this condition. But what we might be able to do is say, do you know what, if we enhance things around it, or if we make things less stressful for that person, then they may be able to cope better. They may be able to function for longer. We may actually be able to, may be able to provide rehab and help this person get better, because we've taken things out that are causing this stress and distress. So stress and distress, I feel, is quite a big move from this suffering through to understanding the person. And there's lots on it. And I would really, really recommend it. I think it's a fantastic way to consider the person and think about different things.
I love your comment about ask why and stay curious. And in that same example, you know, I'm thinking of a client who doesn't have dementia but lives in an independent living facility, and she's not really close friends with the people that she is required to eat with. And so it stresses her out to go to the cafeteria, to the dining hall to eat, because she wants to eat as quickly as possible so she can go back to her place, because she has nothing in common with these people. And it's sterile, and she's an artist and she wants to be around things that are beautiful. And it's like, we all want a positive, relaxed eating environment. And we forget sometimes when things become more institutionalized, if someone's in a facility, that if there's 50 people in the dining room and there's people running in all directions and there's loud music and banging dishes, that can be really stressful. You know? Yeah. So
and small talk.
And look at the whole thing. Yeah.
And some people are just naturally better at small talk than others. And I don't think we always consider that either. Lynn Waddell and myself actually did work years and years and years ago. And we did work with the very, very, as they say in Scotland, the high hegians, the ones with the power. So we actually did some training with the very senior management staff, and we got them to eat together around a table or two, and we did what happens in a normal ward dining room. So we made sure that we knocked behind, because there's never enough space, so we would be knocking people as they were eating. We shouted over the top of people. We had banging, we had background noise, but on top of that, we also used sensory glasses. So we had everyone who either had tunnel vision or cataracts, and we had like used earplugs, so someone could only eat on one side, and how they actually then moved. We had some people where we buddy strapped their fingers to imitate arthritis. We had all these different types of things going on, and we said, this is what it is actually like if you try and create big dining rooms and push people into it. That's why you end up with more challenging behaviours, more stress and distress, and yet eating should be pleasurable. Actually, one of the very, 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 very high agents ended up dropping custard all down ourselves, so you can imagine how popular we were. But sometimes you just need people to get that taste of it.
Right. Empathise.
Realise
what it's like.
Yeah. And you can never, I don't think you can ever understand what dementia truly is. I don't, because unless you're actually going through it and you have the skills to be able to pass it on, I think it's very difficult. So the most you can do is just try best to be curious and ask questions, why and what's happening there, what could it be? And again, that goes down to things like the life story work's really important. Talking to the person, always having pen and paper in your pocket. So that you're actually able to do things with someone, whether it's just a game of X's and O's. Sometimes that's a better assessment than saying, what day do you think it is? Because what you're doing is you're actually seeing whether the person can share, can understand, taking turns, can then hand things back, can terminate a task, whether someone responds, can smile, whether there's a quality to it. So sometimes just the biggest tip you can actually have is have some pen and paper. That person may actually draw you a bell and tell you what they actually need. Well, I've got a list of other things.
One of the things in our last conversation, you talked about washing with words. And if I go back and remember myself as a student, and I was in acute setting, rehab setting, and sometimes we would do an evaluation and the person would be gone the next day. So I went into a room, and it was a woman. I can't remember what her physical ailment was that I was evaluating, but she had dementia, and this was my first interaction with someone with dementia. And I realized I didn't know how to converse with her. I was asked her questions like, oh, so how many kids do you have? Where do you live? She couldn't answer those questions. And then I was like stuck. Well, how do I do my evaluation? Like, she can't tell me anything. And then I didn't know how to like make small talk, because she couldn't respond to questions that I was used to asking in a regular conversation. Fast forward 20, 25 years later, and now that comes easily. But I loved the way you described washing with words. Can you explain what that means?
Yes, it was something I actually read about, and what it is it really goes back to a cognitive assessment. What does a cognitive assessment do? Who's it for? So with washing with words, it turns everything on its head. So instead of you asking questions, what you do is you talk to the person, you give them information. So it's quite hard. It's actually really quite difficult to do. It takes a little bit of practice. So instead of going in and speaking to someone and saying, so how are you? What day is it today? Da, 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 da. And you fall into this pattern of constantly asking questions. What you do is you wash the person with words. You tell them things. So you'll say, so you walk in and go, hi, my name's Kate. Oh my goodness, what a day I've had today. I got absolutely soaked. I can't believe how rainy it is today, considering it's the middle of April. You would imagine that there would be a lot of sunshine today and things like that, but there really wasn't. Absolutely drenched. Feel that hand. Feel it. It's cold. Feel it. It's really cold. And what you're doing is you're orientating people in a way where you're telling them things. So you're giving them the best possible opportunity to then decide if they want to engage with you. And so instead of asking all these questions, which produce silence and produce confusion, and you can feel the person pulling away from because they're quite frightened by you, what they'll do is, more often than not, I've found people will take your hand, or they'll go, "Oh, you're cold, hen." "Oh, I'm colder." And you end up having this conversation where you're telling someone something, and once they feel more comfortable and confident that you're just blethering at them and chatting away, you'll find that people will start talking to you, and they'll start building this confidence, because more often than not, 20 other people have asked them all these questions that day, and they might never have been able to answer any of it, but this chatting away and washing the person with words. So instead of saying, how do you cook? How do you make scrambled eggs? What you do is you say, right, now then, this is, I don't know if this is right, but this is how I make it. This is how my mum taught me how to make scrambled eggs. What she did was, she said, you put a little bit of milk in the bottom of the pan, and then you put butter in, and you let that melt. And while you're doing that, you whisk up the eggs. So what you're doing is you're using, like, you actually end up like mimicking things and getting people to mirror what you're doing. And then you pour it in and you stir it. But seemingly the secret to really good scrambled eggs is to have the grated cheese sitting at the end, and you don't cook it, you just melt it at the very end. What do you think? And sometimes that could be that could be it. And so instead of you actually saying, how do you do it? You say, this is how I do it. What do you think of that? Does that sound reasonable? Do you want to come with me? We can make some scrambled eggs together. And so what you're doing is you're washing the person with words. You're giving them the best possible chance to understand what's going on, and the best possible chance to engage with you, because you are a stranger to them, and you're asking them questions, and you're putting them on the spot. And then you turn around and say, that person never spoke to me.
Right.
That person really didn't have a chance because you didn't hit at the right rhythm with that person.
Right.
So washing with words can do that. It can really help you.
Yeah. I think, I'm not sure when I developed that skill, probably just over time. Like you said, it can initially be challenging, but I know that with my mom in particular, who had, almost 2 decades of dementia, and it was very, very slow. But she was embarrassed. She didn't want anyone to know. And when you can kind of sneak in information that she'll pick up on, and then was very good socially, and can grab onto that information and then use it, instead of feeling embarrassed that they don't remember the person's name, or so I would just give her cues in my conversation to kind of, that she could pull from and use, so that she didn't have to confront that shame or that embarrassment that she was feeling of losing memory.
And it's really difficult. It's really difficult. And even if you take away having dementia, even if you just talk about like being in like any hospital ward, you've got people coming in and asking lots and lots of questions, and you get confused, and you're in pain, and all of these types of things, and the white coat syndrome hits you, and everything like this. So washing with words is a fantastic way of working with anyone and everyone. And that's one of the, you said at one point about the differences between like Britain with people who have dementia and the USA, and I think that's one of the things. We have had dementia strategies released in Scotland every 2 or 3 years for the last decade or so at least. And these strategies have moved from looking at people's right to have accurate diagnosis, and then being offered post-diagnostic support as well. both to themselves and their families. That's became a right that this person is absolutely entitled to, which is really important, right through to having more awareness and more skills working with people in acute hospital wards, physical wards, so that there's this greater understanding. And there's a thing, it's called the butterfly scheme. And it's a tiny butterfly that goes on a patient's notes. So if they do have a cognitive impairment, it goes on, and it's just to remind staff that they maybe need to consider like taking things a wee bit slower, to consider that the person could have these additional issues. And staff went on training, on butterfly training, and we all got a little card, and it actually sits under our ID card. So it just says, remember to think about this, and it just gives you these little pointers. And that came about as part of sort of the ethos within the dementia strategies. The dementia strategies have moved on because they have appeared every couple of years. They've also included things like staff training and what level of training staff should actually be at, depending on how they work with people who have dementia. And the thing that they have said is, which I think is really good, is staff training includes from your reception staff right through. Everyone should have training in working with people who have dementia. Because if you can get these principles right, working with people with dementia, you will just be better at working with everyone.
Right.
And that's, I think, a fantastic ethos. So all of the porters, the staff in X-ray, everyone went through the training, all the reception staff, because they are gatekeepers to services, so they're really important. And that was off the back of the dementia strategy. It was really sort of pushing that we should consider it just really good practice and embrace it everywhere. From there, we've moved on to additional strategies that come out for national work. And we've got things like commitments, so commitments to provide care within palliative care, and how we actually should be considering palliative care through things like prevention, how do we use volunteers, and how do you develop dementia communities. And the dementia communities are quite a new thing in Scotland, where we're actually looking at what do people actually need. And one of the key things is that if you are older, have dementia, any number of reasons, you need to be able to use your community, because we all know that if you go out and you get more sunshine and more exercise, you're less likely to need things like medication to assist you in sleeping. If you don't have medication that assists you in sleeping, then you're more alert in the morning, you're less likely to have falls. If you're less likely to have falls, you're less likely to be in pain, you're less likely to need pain relief, you're less likely to have issues with your stomach, you're less likely to have digestive problems. It's a spiral that if you can break part of it, and that can include encouraging people to go out in the community, make sense of the community for people, have afternoons or early evening shopping sessions that are for people who either have autism or who have dementia, things like that. Pull people back into the community. Don't warehouse people. Don't warehouse them waiting for death. Actually say, these people have got things to contribute. They've still got a life. They've still got all of these things. I was working years ago. I was working with a lady when she was first diagnosed with dementia, and oh my goodness, she'd cause a row in an empty house. Honestly, she was just she's quite terrifying. And my daughter was equally. They had a very, very, very difficult relationship. It was very much, and I'm not talking to her, and I'm not talking to her. And oh gosh, it was like refereeing things, getting anything done, and. I actually, must have been about 15, 20 years later, I actually was in a ward by accident, and I walked through the visiting area, and visiting areas are wonderful. It's great to always allow yourself an hour and a half extra, because you get a chance to have a wee dot about and speak to people and all this sort of thing, and the things you learn is amazing. But I was walking through and I had someone else to see, and this lady who fought with everyone, she did. I think she campaigned for everything. I think she annoyed local councillors. She was just one of these ladies. She was who you always want to be when you're older. You just want to be out there causing bother because you can. Anyway, but our daughter had quite a hard time of it. And I ran into Molly and her daughter. And Molly was sitting with her daughter and they were hugging. And Molly was never a hugger. Never, no. Keep your distance. It was very, very clear. And they were sitting eating a bag of Maltesers together. And Molly's daughter actually said, could you come and see me after? I was like, yeah. So I popped out to see Molly's daughter afterwards. And I said, so how are you? I says, how are things? I says, you've gone through my mind a few times. And she says, yeah, she says, as the dementia progressed, she says, I actually got to know my mum more. And she says, and she let down a lot of the barriers. She says a lot of it was to do with my mum's pride. She had been sort of told that she wasn't very clever at school, and her mum had been dismissed, and she'd always felt less than. She says, I was illegitimate, she says, which was quite a big thing. She says, I didn't know, and my mum eventually started talking about that. She says, and as things went on, she says, we formed a relationship. She says, and we probably have a better relationship now than we ever did. She says, because my mum smiles and we hug and we cuddle. And she says, my mum probably doesn't know exactly who I am, but she knows that I'm someone that she loves and that I love her. And she says, so we sit and we have wee picnics and we sing together and we hug and we do this. And she says, I have a relationship that I never ever thought. She says, and when the diagnosis was first given, she says, I was terrified and I was frightened and I'd been told all these horrendous horror stories. And she says, and some days are as bad as that. She says, but there's other days where I'll go to the door to see my mum and she'll hug me and she'll cuddle me, and then we'll go and sit and she says we'll share a bar of chocolate or we'll laugh, or she says, and it's a different relationship. And I think that that's quite an important thing, is that it was different. It wasn't necessarily less than, it was just different. And she would never have wished that on her mum, because I think she still wanted her mum to be this feisty, shouting at the neighbours, and any time a ball was kicked into the garden, stabbing it with a pair of scissors. I think she still wanted that mum, but she got a mum that she also really loved, and who loved her. So
yeah, thank you for bringing that up, because often there are blessings in disguise, and as challenging as dementia is for obviously the person that has dementia, but also for the family and the caregivers that of them, there are sometimes these silver linings where barriers are broken down and new connections are made, and relationships can even improve and blossom.
Yeah.
And when we talked previously, you mentioned that even in very late stages of dementia, that often the ability to detect emotion is still very strong, even if language is no longer there. Can you touch on that a little bit?
Yeah, there's a body of research to support this, but also personally I've seen it. I remember I'd had a really bad day and I walked into the ward, and I have to admit I was like, oh, and I can't remember what it was. I just remember there was something that happened that was just really, really bad. And I sat down, and one of the ladies actually came to me and gave me a hug, and she just looked at me, and then she walked off, and I thought, oh, I really needed that. I so needed that. And that's what happens sometimes. The lady, when I was on the phone, and she took my hand and she was looking at my rings, we sat, we didn't say much, we sparkled and we looked, and I probably said, look at my nails, I've been out in the garden and they're full of mud, and all these types of things, because they normally are. And so this physical touch can be lost. And a lot of the times it's, again, because we talk about safety, it's because we talk about, oh, no, you can't do this, you can't do that. And yet we are affectionate beings, we are touchy, we are feely, and yet quite often when people are in, especially in institutional type of care, there's just this lack of touch unless it's doing something to the person or for the person rather than touch for just the touch of it. And I've done some dancing sessions and they have been, they're such a lovely, legitimate way of being able to touch and things like that. Plus, they're obviously fantastic for people's balance, and they're great for postural drainage and all these other medical reasons. They're fantastic to do dancing, but sometimes just the actual touch and the smile, and then the discussions that you have afterwards where it was my favourite dress was midnight blue and all these types of things. It just opens a flood of memories that are the most wonderful things to experience. And you really do get some amazing little snippets where you think, oh, remember that, that was wonderful to hear that. Or they'll tell you, I used to do lots of home visits where I would take the person home. And part of it was to see whether they were orientated in their environment, and the amount of things that I learned whilst in the car, because it's such a usual and normal activity to do, is to talk about what you see. Oh yeah, and I did this, and that shop was there, and all these types of things, and just putting these things into place so that you get a chance to see the person. I've saw on I don't know, you must have seen it, but lots of things on things like Facebook and YouTube where people will actually go out with their granddad or their dad and they'll play music in the car and they sing, and oh my goodness, it's amazing to actually watch them do that, because it's a usual thing to do. It's just sing in the car. So why not do it? Why not do it? Right. So you will find that you just get different types of responses, and people even in very late stage will still want to express or have the ability to express some wonderful emotions, a smile or a tear. And just because someone has dementia doesn't mean to say that they're not allowed to experience other things and emotions and also give you a little bit back as well.
Right. That's one thing that I miss, that as far as I know, it doesn't really happen in the United States anymore. It happened very early on when I was a student, but I don't think there's many environments like I experienced in Scotland, where I helped somebody transition out of the hospital back home. And that's such a powerful transitional time. And I miss not having that opportunity anymore. And I don't mind sharing my outspoken opinion after having experienced universal healthcare in the UK and in France, that I'm a big proponent. So thank you for mentioning like the dementia strategies and the butterfly scheme and the Carers Recognition Act, and the benefit of being able to train everyone across the board on the same thing. Whereas here it's very piecemeal. Like you might get a good organization that is doing training top to bottom, but then you might get lots and lots that don't have the same kind of training. So thanks for touching on that. And I wanted to share, when you were talking about the emotion and late stages, if Mary Taylor happens to be watching right now, she was my mom's caregiver the last 2 years when she was mostly bedbound, and she, needed maximum assist transfer from the bed to a chair and to get dressed, and to she was incontinent, so she was getting care all day long. And Mary would say that coming into my mom's room was actually a joy, because my mom would light up, because this Mary was like the person that you mentioned earlier. She was a mom-like person who was just caring and loving. And so my mom would light up when Mary came in the room, and she would rub her arm and kiss her hand in gratitude, so there was this really positive connection, these silver linings for both of them. Yeah. So sorry, I had to jump back and share a couple bits of things you made me think of. Did I interrupt your thought?
No. I think it's such a lovely thing to actually share these types of things. And I think that we're inclined to actually forget the funny things, or the daft things, or the smiles and things like that, because sometimes we're so busy writing notes, and so said this, and they ate like 500 calories worth, which was fine, and everything like this, and we're so busy with this and measuring that sometimes we actually forget that a smile indicates a quality of life. And Tom Kitwood, 3-4 decades ago, actually wrote about that. And he wrote about quality of life, and measuring it is someone's ability to be able to share and to smile and to be settled and relaxed and all these types of things. And he actually has lists of things to look for, which I think is really important, is look for it. Don't forget to look for indicators that this person's feeling good. Because sometimes asking what day and what date it is makes you think, oh my goodness, this person doesn't know this, doesn't and can't. Whereas a smile and them being able to choose a chair that they're comfortable in, and they're patted so you'll sit with them, and all these types of things, these matter, because that's something to do with quality of life and how the person can still express that quality. And you can't be a caregiver unless you get something back, because you'll burn out. So you have to sometimes just look for it.
Kate, thank you for your 34 years of service of helping bring meaning, to other people's lives, and to sing with people and find the positive. And I know you were an amazing occupational therapist, but you were also an amazing teacher and mentor. And thank you from me. And I'm sure that there's many, many, many others out there who thank you for the work that you've done.
It's been a pleasure. It was a pleasure working with you. I think I said that to you. You actually, your daughter was just a tiny little thing, and I remember us being in the house once and turning around, and you were sitting there with your cheeks full of food, and I was like, "What are you doing?" And you went, "I'm breastfeeding." I went, and that was great. I was surprised. But the other side was that I think it was quite nice, because that showed how comfortable you were doing that in this lady's house. And I think this lady found it funny as well. I was like, Laura's got a wee one and she's breastfeeding. Oh, I remember that. And I think we ended up having this big conversation, and it did. And that's my image of you, that, and having coffee jars that you would open, and there'd be soup in it, and you gave me a recipe for pumpkin muffins, which were fabulous, by the way. And so yeah, it was such a pleasure, such a cultural difference actually working with someone from America, and it was lovely being able to actually find out more about the training and what happened. And there's one last thing to say.
Yes.
Going back to the putting the hands up. Mm-hmm. Just to say that in the last 20 years, I've had a much more management post. I've still managed 20 hours or so a week minimum, apart from the last 2 years, because COVID has changed everything. But up to then, I still managed at least 20 hours a week, face-to-face, hands-on, with older people or their carers, which is such a powerful thing to be able to do as a manager, because you can go into meetings and say, I last saw, or I spoke to someone who said this, and I think that's really powerful. But the other thing was I did recruitment, and for 20 years at least, we have never had a gap in our service. We've always had lots of people apply for the posts, and we've had ex-students come back and actively seek to work in this area, and that's amazing. And I'd like to think that if we asked the same question and said, would you work in this area? I'd like to think that there'd be people with their hands up now compared with how it was 4 decades ago. And I think that probably is the case, which is lovely.
And you played a role in that, Kate. Pat yourself on the back.
And so did you. I think everyone who had a positive impact on the care has played a role in bringing other people into it, which I think is wonderful.
Yeah. So I'd like to finish up by sharing what you're doing nowadays. And, you know, we reconnected on Facebook, and I saw that you were working on a book. Actually, it's a trilogy now, right? And you have it all in one book. So I started it this morning, and it's hilarious. Like I was crying, laughing so hard, even after I closed the book, in the kitchen making my food, still laughing, recollecting parts that I had read, and I can't wait to share it with my family members. But there's a story behind this book. If you don't mind, would you be willing to share?
Yes, this book is by no means at all related to my job or my previous work. What it was my husband was diagnosed with a condition that affected his memory and cognitive skills, and also his emotions. It's quite an unusual condition, and it was very, very difficult to find cognitive rehab. So once he'd been in hospital, he'd had a major seizure, he dislocated his shoulder. He was really, 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 really ill. He nearly died. It was very, very traumatic. Oh, I have permission to share this, by the way. He's very comfortable about doing this, and he worked with healthcare as well. So once he was out of hospital, his cognitive skills had gone from, say, 100 out of 100, which it would have been, I would imagine, although I'd never tested them. You can't really do that. Seemingly they don't like it if you just randomly test your husband. But it had actually dropped from 100 down to 72 out of 100. So there's quite a significant drop in his actual skills. At one point, he didn't recognise me. He didn't know where he was. He was really quite profoundly unwell, and it was very, very sudden. So we tried to find things that we could do together. And one of the things we began doing was, instead of saying what day it is and what date it was and all this type of thing, because that would just really distress him, and it wasn't something as a wife I could do, and I didn't want to do that to him. We began talking about characters, and it was like, so if someone did this, what do you think they would do? And so we ended up creating these fantastically strange characters who were just really badly behaved. And so we had all these stories. So we began talking about stories, and we began talking about things that the kids had done when they were younger, because not only had my husband his cognitive skills dropped quite substantially for the here and now, but he'd also lost about 10 to 14 years worth of memories, and especially memories associated with emotion, because it impacted his limbic system within his brain. So reconnecting was really important, and being able to talk. So we spoke about photographs, but sometimes my husband would be, I can't remember that event, I don't know what that is that happened there. So we began talking about like daft things, like when my son got stuck inside his duvet because he wanted to check and see whether the outside of it was the same colour as the inside. Yeah, he did things like that. So we began talking about stories like that, and we began constructing it in a way of telling stories. So it wasn't, oh, remember that date and this happened. It was, oh God, do you remember the thumping on the floor and the shouting? Yeah, we had to go and rescue him out of a duvet. Did we? Oh yeah. Why did you do that? Telling them about it. So it was based a lot on the washing with words type of thing as well. And so we ended up with lots and lots of stories. And I've got a friend who's from Kansas, and so she would ask how things were and all that, and I'd tell her stories of where we were at and things, and she actually said, you know, you could write a book. Probably could. No, seriously, you could write a book. And so we started writing a book with all these fantastical stories and people that we knew, also people that we definitely don't know. Like, please don't think that we know everybody like this, because otherwise, like, these people should be in jail that we've written about because they're so badly behaved. But some of the stories incorporate things that my husband forgot and then began to remember. So after, must have been about 6 or 9 months, my husband went back and was reassessed. and his cognitive skills went from 72 out of 100 to 97 out of 100. And he got his driver's license back, which was really important. Yeah, it was a big freedom thing for him. And he continues to have days where he has a bit of a struggle, but the actual rehab process has proven to be really successful, and pulling the book together and using that to discuss things and to talk about emotions and to talk about just being naughtiness and being wild has been really good for both of us. So although the book is absolutely not about people who have dementia, and it really, really is not, I can't stress that enough, it's a collection of stories that we've managed to pull and weave together into 650 pages of ridiculous nonsense and naughtiness. And we're actually writing book 4. So just before I came on air, we were having a discussion on whether criminals could actually train chickens to walk up walls and sit on cameras and hide cameras, so that grannies could do a Catherine Zeta-Jones and dance through laser beams to go and steal chickens. Kid you not, that was the conversation. And I thought, see if anyone's listening to this, they'll go, they are weird people. And I was thinking, we are weird people actually. But that's the opening, or one of the opening chapters we're considering for book 4 is thieving grannies who train chickens called Doris and Henrietta to go and sit on cameras to block the view while they go and steal diamonds. There you go. I know. It makes sense. It will make sense once it's in the book. But I'm glad you're enjoying it.
That is fantastic. So it's called The Devil's a Searching. I picked it up off of Amazon and it's hilarious so far. So you picked a meaningful activity for you and your husband to do together. It was the Just Right Challenge. It is the art of doing in occupational therapy. I have to say that I didn't come up with that title, The Art of Doing. It was on a t-shirt when I was in grad school. So I don't know who to credit it to, but I think it describes occupational therapy very well. And thank you for helping me celebrate Occupational Therapy Month and honor a profession that is a calling for many, you and I included. Yeah. Oh,
Mrs. B, it's been wonderful having a chat. I do apologise for talking far too much. And can I tell you,
yes,
there's about 20 other stories I've got here.
We might have to do part 2. I think we might have to do part 2.
There's all these things that I've done and things that have made me go, oh, no, that was a safety one. And all these types of things, because life probably is a collection of stories and how you interpret them and what you do with them and how you share them. And that's very much how people did it years ago, and it still has probably as much power now, which is lovely. Hence the reason that Facebook's so popular. Well, that and you being nosy and wanting to find out what your ex-boyfriend looks like and hope that he's actually gone bald. But it is 7:45 here, so I am going off. I have got a tub of hummus in the fridge, which I'm sure is due to go off quite soon unless I go and eat it. And there's a bottle of red wine that I'm just about to uncork.
Oh, well, I hope you have a wonderful evening. Thank you for sharing your time with us here.
Thank you. It's been wonderful. Thank you. You're doing a fabulous job. Keep it up. Well done.
Thank you. Good night.